speech along with me if you wish. As chairman of the House Health, Human Services, and Elderly Affairs Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic, and in accordance with House Rule 67 and the Governor's Emergency Order 12, pursuant to Executive Order 2020-04, this public body is authorized to meet electronically. This is a public hearing and executive session. Please note that there is no physical location for members of the public to observe and listen contemporaneously to this meeting. However, in accordance with the emergency order, I am confirming that all members of the committee and select legislative staff have the ability to communicate contemporaneously during this meeting through the Zoom electronic meeting platform, and that the public has access to listen contemporaneously and, if necessary, participate in this meeting by the Zoom platform or by telephone. All necessary and access information has been made available in the House calendar and through the electronic calendar on the General Court website. The notice for this meeting complies with House rules and with RSA 91A. Anyone who has a problem accessing the meeting should call 271-3600 or email hcs@leg.state.nh.us. In the event the public as a whole is unable to access the meeting will be adjourned and rescheduled. Christina Dyer is the staff member assisting us. Please note that all votes that are taken during this meeting shall be done by roll call vote. We will start the meeting by taking a roll call attendance. When each member states his or her presence, please also state whether there is anyone in the room with you during this meeting, which is required under the right to know law. Would the clerk please call the roll?
Chairman, I don't believe the clerk is on the call.
In that case, here we go. This is in a different order than you're probably used to. Dennis Acton.
I am here and I'm alone in the room.
Jerry Cannon.
I'm here in Somersworth and I'm alone in my home.
Leah Cushman.
Present in the committee room.
Beth Folsom. Betty Gay. Please hang on one second. Hello, Madam Clerk. We are in 301.
The other clerk is coming.
She is. Nikki Kelsey. Bill King. Jerry Knirk.
Here in my study in Freedom, and I'm alone in the room, but my wife is in the house elsewhere.
Jim Kofalt.
I am here in my home office in Wilton, and there are other people in the house, not in the room.
Jim McKay.
Present and yellow bait.
Bill Marsh.
Present, yellow bait.
Charlie McMahon. I have seen you.
See him on the list right now.
Okay, I thought I saw him. Gary Merchant.
Here in Claremont in my home, and there's my wife is somewhere else in the house.
Bill Nelson.
Here in Brookfield, and my wife is somewhere in the house.
Yeah, they changed it on us.
Francis Nutter Upham.
Hello, I'm here in Nashua, alone in my living room.
Mark Pearson is here in the LOB. Jeff Soloway.
Present in Lee, New Hampshire, in my home office, and I am alone.
Joe Shapiro.
Present in my home office in Keene, alone.
Kendall Snow.
I think he's coming here.
Lucy Weber.
Present in Concord, alone, except that there are carpenters immediately outside the house.
Carpenters. They've only just begun.
They have only just begun, and I fervently hope they will finish soon.
I got it. I did.
Gary Woods.
Present, I'm here in my study in Bow, and I'm alone.
Now we're going to do a second run through since people found us. Beth Folsom.
Here. LOB.
And Betty Gay.
Present, finally.
And Nikki Kelsey.
Here in the LOB.
And Bill King.
Here at the LOB.
And the only one I'm missing, the only two I'm missing is Charlie McMahon and Ken Snow.
Don't see them all.
And I promise not to be so informal the rest of the meeting.
And Mr. Chair, I'm going to leave now to go to my other meeting. I'll be back before 10, I hope. Thank you.
Okay. I am opening the hearing on Senate Bill 45 relative to the Controlled Drug Prescription Health and Safety Program with Senator Bob Guida as the principal sponsor. Senator Guida, would you introduce your bill to us, please?
Thank you, Honorable Chairman Pearson and members of the House Health and Human Services Committee. For the record, I'm Bob Guida, State Senator for District 2 and prime sponsor of Senate Bill 45. Senate Bill 45, as amended by the Senate, adds some key data sharing provisions to the Prescription Drug Monitoring Program, or Pdmp. Specifically, in Section 1, Roman 4, we add medical reconciliation to the definition of services delivered by a dispenser. Under CMS, the definition of the term medical reconciliation means, quote, the process of identifying the most accurate list of all medications that the patient is taking, including name, dosage, frequency, and route, by comparing the medical record to an external list of medications obtained from a patient, hospital, or other provider. Under Roman 4, the bill adds one additional category, Parent F, to those excluded from being considered as dispensers, specifically a practitioner who neither prescribes nor dispenses and who is not actively working as a pharmacist within New Hampshire licensed pharmacy licensed under RSA 318 or New Hampshire healthcare facility licensed under RSA 151. What this does is to exclude non-practicing professionals from gaining access to Pdmp data. In Section 4, the bill adds under Parent 4 the ability of pharmacy, nursing, physician, licensing, and other participating boards to use Pdmp data in treating impaired members of their professions. At this point, I feel it's important to speak why the original bill was amended by the Senate. It was amended to delete any references to the Pdmp data sharing program with the Department of Health and Human Services, given that the Pdmp is being moved from OPLC, the Office of Professional Licensure and Certification, to DHHS. Though this makes administrative sense, the Senate had several concerns with the move. First, DHHS seeks to use Pdmp data for public health programs and analyses, but the program was never intended to be used for public health purposes. It was intended to identify individuals, not to analyze populations. Any such potential expansion of the program's intent merits careful scrutiny by this legislature prior to its implementation and will be the subject of future legislation. Second, the legislature's privacy mandate regarding use of Pdmp data was clear and unambiguous and was underscored by the public's overwhelming support for the 2018 CACR that added Article 2B to our New Hampshire Constitution, prioritizing our personal privacy as a constitutional matter. Clearly, data privacy is of paramount importance to the people of New Hampshire, Unfortunately, a DHHS attempt to provide Pdmp data to the federal government to garner grant funding was discovered and prompted the Senate, mindful of the obvious data privacy concerns, to remove DHHS data sharing provisions from this bill and to address it in separate legislation. This concludes my testimony on Senate Bill 45. I ask for your committee support for this bill to improve the utility of the Pdmp while scrupulously maintaining the privacy of its data. And I'm happy to answer any questions, Mr. Chairman.
Any questions for the senator? Representative Marsh.
Yes, thank you, Senator, for coming before us today. Can you hear me?
I can hear you.
Oh, good. Given that House Bill 2 repeals the section.
Now, I can't hear you now, sir.
Sorry.
What is?
I think
Someone's microphone.
Feedback in the background.
Are we better now?
We're better now.
Okay, good. Given that House Bill 2, Section 39, repeals the section of law that this bill would amend, and given that these data sharing provisions are really quite important, do you have any feelings about perhaps you're introducing this language to House Bill 2 as an amendment, so it goes to RSA 126A as the Pdmp seems to be being moved to that section of statutes, and having our committee retain this bill so that you can work with us to fix any issues that remain after the passing of the budget.
I'm amenable to whatever gets the job done, Representative. And as we all know, the vagaries of the political process can sometimes be confounding and frustrating. But I'm happy to, do whatever it takes to get this into legislation. It's good legislation that needs to happen. That will enable, for example, the nursing profession, the licensing boards for nursing doctors and so forth, to assist those members of their professions that are struggling with drug abuse or misuse. So, again, I think it's an important addition, and whatever it takes to get it there, I'd be happy to go with.
Thank you. I agree with you, and I appreciate your flexibility because we do have that issue with you.
Does anyone else have a question for Senator Guida? Representative Gay.
Thank you, Mr. Chairman. Thank you for taking my question. I have to reveal my total ignorance on this. It sounds like in your explanation that we are trying to protect people who should not be, who are drug dependent. And yet the other issue seems to be we're protecting people's medical privacy. Could you clarify the intent of this rule of this law and how it somehow can be manipulated so that data can be shared?
Thank you for the question, Representative. So currently, and I would suspect there may be others that will testify more in depth to this, but currently, what the purpose of this legislation is to enable hospitals and doctors to incorporate this data into their electronic health records of individual patients that they're seeing. All right. There's also a financial matter that we are eligible for additional federal funding through Medicaid by enacting this legislation for the purposes of Pdmp. The data, there's a study done in 2018 by the New England Journal of Medicine that conclusively showed that the use of this Pdmp facility, when combined with expedited clinical access, provides better outcomes all the way around. And so, again, we are protecting the patient's privacy. We are enabling the patient's providers, the doctors and APRNs and those professionals to access this data electronically, automatically, but still with the protections that are both HIPAA provided by the provider, the doctor and the office, so and also holding responsible anyone that has access to the data.
Any further questions? Representative Weber.
Thank you, Mr. Chairman, and thank you, Senator, for taking my question. This is really rather a process question, and it's perhaps is better reserved for our executive session, but I want to know your thoughts on it. Do you join me in thinking that it is really better to keep policy matters that do not have a financial implication out of the budget and the trailer bill rather than sliding them into the budget or the trailer bill because they are policy and not having to do with the actual budget?
That's an excellent question, and one which I deal with on Senate Finance starting yesterday. I would be amenable to whatever gets the job done. This is not a financial implication bill in any sense.
Mm-hmm.
But the medical profession, the hospitals, the pharmacies are all looking for this ability to electronically access with significantly less work by the accessor. There was a concerted effort to access the database, and every access takes a physical action. This would provide electronics. I don't have a concern as to putting it in trailer bill or putting it as separate legislation. My concern is getting the job done so that these folks can use that Pdmp to better identify and treat patients who are in fact substance misusing.
Well, I understand the urgency of the concern, and thank you very much for the question, for the answer.
Representative Shapiro.
Thank you, Mr. Chairman. I think Representative Woods has had his hands up for quite a long time, but I'll go first, I guess. Thank you, Senator, for taking my question. I am wondering if in the process of incorporating the results into patient records, if there's some kind of explicit consent from the patient for doing so.
That was discussed, and in fact, there's notification provided in the doctor's office. There's no notification currently given when they access it now. And in fact, if I'm not mistaken, it's required that medical professionals do this. Perhaps one of the medical doctors on the committee might better clarify that. But I again, it's not produced now as are you aware of the fact that we're querying this? This is it's a policy that's in place as we speak.
Thank you.
And if I might, the data is then used anyway by the medical professionals. So I don't see that as a concern at this point. Thank you.
Representative Woods.
Thank you, Mr. Chair. A quick question first to you. Are you looking for my visual hand or the raised hand electronically?
I'm looking for Representative Marsh's cue.
All right. Well,
Raised hand,
thank you, Mr. Chair, and thank you, Senator, for taking my question. First of all, having been an orthopedic surgeon for many years, this process, were it fully in place when I was actually taking trauma call, would have been a great assist for me getting phone calls for prescriptions on the weekend. My question is, I have a little bit of concern perhaps because I don't understand the difference between the front end and the back end of this process. The front end being on page 1, line 26 through 28, the electronic health record keeping system owner or license holder shall be responsible for ensuring that only authorized individuals have access to the program information. I'm assuming that's individuals in, say, if I were in practice, in my office or in the hospital. So on the back end, the PDPM, how do they know that that's a designated individual? Does each individual on the front end have a code that has to be designated to that individual and then registered on the back end with a PDPM? How is that? Because otherwise an individual in my office may say, oh, well, Aunt Susie just went to the I wonder what medication she's on, and then tickle that in through the office into the PDPM. So is there how does that functionally work from the front end to the back end for security purposes?
The only access, only people that are registered by the office that's using the Pdmp system are authorized to access that data. So they're specifically named. Yeah, they're specifically named.
Does a PDPM know that by code?
I don't know the answer to that. I don't know the answer to that.
Okay, thank you.
Dr. Strang from the department is on the call and signed up to testify. He may be able to answer that question later.
Well, he could answer that now if he wishes.
If you wish to call on him next.
Yes, I do. Dr. Strang, this is initially for the purpose of answering Representative Dr. Wood's question, if you can.
Can you hear me?
Yes.
So thank you for that question, Representative Woods. So right now, in order to access data through the Pdmp, one has to be registered and given login data, which typically consists of an email address and a password. That's how I access the program as an emergency physician. If I were in an office-based practice, we likely would have other office staff, such as a nurse or a clerical staff, who would sort of be teeing up the patients for the day's visits, and they can access the data to have that information available when I go in to see the patient. But they must be registered under the name of a surrogate, me, for example, and they are given individual specific access data. So when they go in to tee up the day's patients, an electronic footprint is left so that the program managers can actually go in and see who accessed that data. That would specifically prevent me, for example, if I were snooping and looking to see what you might have had prescribed or the governor would have prescribed. If I were foolish enough to do that, it would leave an electronic footprint. And if that information were inappropriately disclosed, it could easily be determined who had done that illegally.
Thank you, Dr. Strang. I know that was the case for general electronic medical records. I didn't know if it had carried over to this program as well. Thank you.
Yes, it has.
Further questions for Senator Gaida? And Representative Merchant, is this for Senator Gaida?
Thank you, Senator, for taking my question. And it actually goes to Senator probably Dr. Strang. In regards to the database, I understand that the patient can have access to find out who's been accessing their data within the database within the program itself. So there are footprints within the database that a patient can ascertain and find out. Once that data leaves that database, how does a patient then access inside of a healthcare entity who has had access to their prescription information? Because no longer it's going to be within the confines of the prescription drug program database. Now it's into another database. How does the patient know that someone's been tampering with or looking and snooping into their records over there regards to their controlled drugs?
I'm not sure I agree that it goes into another database. It goes into an electronic health record. The access to which I'm sure is controlled by the physician, the office, perhaps the office manager. So I think that the disclosure of that data is going to require access to it, and that would be fairly easy to trace.
Follow up.
Follow up.
Thank you, Senator Gutter, for the answer. since it's leaving one database, it's going to health record, which is really another database electronically. Would it be wise to have the patient have sort of written consent, because we're moving physically the data from one database to another database, so the patient's aware of the fact that it's leaving the confines of one program and going into another electronic health record, that they are actually giving their consent?
I believe that. I don't have a problem with that, but again, I would think the medical professionals might weigh in on the effect that has, potential chilling effect of discovering a person that is misusing. And so the notice is given in the doctor's office. That's a requirement of the statute, that your Pdmp, you're being researched on the Pdmp basically. But if you were to require people that are abusing to consent in writing to discovery of their pharmaceutical history, if you will, you're going to have a significant chilling effect on the very purpose for this program. I know that we had discussions about that. And again, at some point, we have to trust that the doctor's offices and the hospitals are going to be trustworthy. Again, everyone that accesses that data is by name identified anytime they access it. So again, it's easy to trace, certainly to an office, in which case liability could be assigned for a breach.
Further questions?
Representative Gay, then Representative Cushman.
Thank you for giving me permission. Thank you for taking my question. I'm not sure who wants to answer this. It sounds like we do have a system of protection so that there's a record of who accesses information. And now I'd just like to get down to the fine point of, does the person in the office, the doctor's office, have a different ID from the doctor himself, or not doctor, whoever the practitioner is? So that's a great comfort to me that there is a record. But like you were saying, somebody might want to know how Aunt Susie was doing. So does it say the person who accesses, the office staff, or does it just say the office?
Thank you for the question. Each person that's granted, I want to say the term is licensee, but I'm not sure that's the right term, but each person that's granted access is individually identified with their own unique password. So it's specific to who accessed the database for what patient at what time, and very traceable.
Thank you. So that means that the person, the staff person in the office, has their own identity.
That's correct.
Thank you.
Representative Cushman.
Thank you, Mr. Chairman. Thank you, Senator, for taking my question. I was wondering, so is this for all medications or only controlled substances?
Yeah, it's not all medications. It's controlled substances. I think Schedule 2 through 4, I think, is the appropriate terminology.
Thank you.
Narcotics, yeah.
May I have a follow-up?
Follow-up.
Can you clarify the limits that will be placed on Department of Health and Human Services access to this? And are there any other government entities that could access this?
Yeah. Currently, there is no access by DHHS. I chaired a working group here, I want to say 2, maybe 3 summers ago, in which we got all the stakeholders together. And we started working, towards a massive change to provide massive access to a DHHS, and it just got to be too cumbersome. So we've broken it into bite-sized chunks, if you will. Right now, DHHS cannot access that data. And again, that'll be the subject of separate legislation that we very carefully scrutinized, because again, this was never intended to be used as a database for public health analysis of populations. It was intended as an individual, assist to individuals by individual doctors or individual medical professionals. That transition or that expansion is one we have to watch with great care. Again, given the mandate for privacy, That was the initial legislation that established PDMP, the concerns for maintaining that privacy, and of course, the recent constitutional amendment.
So how are they going to do it? How are they going to share it?
Thank you.
Any other questions for Senator Gaida? One more, Representative Gay. We don't want to keep you from the fun of working on the budget.
Oh, do, please.
Should I? Thank you. Should I ask a really long question?
No.
No. Okay. Okay. It sounds like that we are building in all these protections, thank goodness, but we are still going to access some of this information to benefit from federal money. Do I understand that correctly?
No. The federal money would be an ancillary benefit. It's not, we're not doing this for that purpose. We're doing this to enable the medical professionals to streamline safely their functionality in their offices and in the hospitals, emergency rooms or whatever. And so it would be an ancillary benefit. It's not required. This program is fully funded under the state budget. So, you know, if we wanted to go after Medicaid funds for Medicaid people, for folks that treat them, that's a possibility. It's certainly not. It's not a driver in this legislation.
Follow up.
Representative Weber. Representative Weber.
Working on finding the unmute button, sir. I believe Representative Cushman had a follow-up.
Oh, I got my follow-up.
She got her follow-up.
Thank you.
Okay, thank you. I just wanted to be sure to clarify, is it not the overarching purpose of this entire legislation that we want to ensure that controlled substances are not being misused, and the purpose of the legislation that we have before us now, that was the existing legislation, and that the purpose of the legislation that we have before and now is to streamline the process for professionals who were having to make really lengthy and cumbersome inquiry. So we are hoping to get ourselves to a point of somewhat more streamlined questioning of the database. Is that correct?
That is a good assessment, Representative.
Thank you, sir.
Seeing no other hands, thank you, Senator Gaida. Go have fun.
Thank you, Mr. Chairman, members of the committee.
But before you do, I believe you were reading a prepared presentation to us. I know you're very good at speaking, but that was really good to the level of you had to be reading some of it. So could we have copies of it?
I've already instructed Griffin, my assistant, to send it to all members of the committee. It may already be in your inboxes.
We have it already.
Thank you very much. I'll look
Thank you,
for it.
Mr. Chairman.
Thank you, Senator. And now the chair would like to bring back Dr. David Strang to make your presentation of anything you wish to tell us.
Well, thank you very much. Good morning, Mr. Chairman and members of the committee. My name is Dr. David Strang. I am an emergency physician and chairman of the Advisory Council for the state's Pdmp, the program to which this bill applies. I want to be clear, though, that the council has not met since this bill was modified to its latest version, so I am not here to relate a formal recommendation from the Advisory Council on SB 45. That being said, though, in prior meetings, there was clear support from the council members for the concept of integration between the Pdmp and electronic health records, also known as EHRs. In my professional opinion, this integration is the most important part of this bill. Currently, in order to access Pdmp data for a patient that I'm treating in the ER, I have to leave the EHR, go to the desktop, click on a web browser such as Google, type in New Hampshire Prescription Drug Monitoring Program, hope that the search brings up the login page for the Pdmp. If not, I have to navigate to the login page, type in my email address and my password, which I remember because I use the program enough, but others might not. Then I have to navigate to the patient information page, By now, I've forgotten the patient's name and date of birth, which is the minimum data that you have to put in. So I have to put that information in, and then and only then can I access data for that patient. I think you can understand that's a lengthy process that might deter many from using the program. This bill would allow integration such that all I would have to do while in the EHR for a specific patient is to click the Pdmp link, and the EHR would automatically connect me to the Pdmp for that patient and that patient only. This bill would streamline the process tremendously, resulting in greater usage of the program and adding greater safety to the process of controlled substance prescribing. After all, that's what this program is all about. This bill doesn't allow greater access. In fact, some of the other housekeeping language, such as in lines 14 through 16 on page 1, actually closes loopholes that might allow inappropriate access from retired practitioners. So I thank you for your consideration this morning and respectfully ask that you support this legislation, and I will be happy to answer any questions that you might have for me today.
Any questions for Dr. Strack? No? Seeing none, thank you so much for your testimony.
Thank you very much.
And the last person we have signed up to speak is our friend Paula Minihan. From the New Hampshire Hospital Association.
Can you hear me? Good morning, Representative. Can you hear me now? Okay, great. Thank you. Good morning, members of the committee. My name is Paula Minihan, Senior Vice President, State Government Relations for the New Hampshire Hospital Association, representing all our hospitals. The Hospital Association does support Senate Bill 45, and I am specifically testifying on paragraphs 2 and 3, which Senator Gaida and Dr. Strang have been very clear in explaining that. But I want to just thank Senator Gaida. He did sponsor a very similar piece of legislation, Senate Bill 676 last year, but unfortunately, due to the pandemic impacting the legislative process, it did not move forward. As Dr. Strang has indicated, this program, what we really are trying to do is just to create that interface, and it's the EMR Pdmp interface. That's really what this legislation does. It is not changing, as Dr. Strang said, the program, the underlying program, which has been in effect for years and is a very important tool for practitioners. But we are just trying to eliminate actually the manual process that Dr. Strang explained, and is really problematic because it adds a lot of complexity and unnecessary administrative burden. And this is actually a much better way to ensure that the data is getting into the individual's EMR and electronic medical record. So that's really what that does. And as Senator Gaida explained, we did have a lot of discussion when this original bill was introduced a couple of years ago. Time passes quickly, but I think it was actually when we had that discussion, it was either the summer of 18 or the summer of 19, when we had that stakeholder group. And we talked about protecting the patients, making sure that they understand the data and making sure, obviously, that they have HIPAA protections, which of course they do. So we added paragraph 3 to ensure that there is the confidentiality component. That was raised by some of the senators prior to this not getting through last year. So that's really my testimony. I have submitted some testimony, written testimony that you, I believe, have. I'm happy to answer any questions. I understand Representative Marsh's point relative to the budget. And again, I will reiterate what Senator Gaida said. This is very important legislation. We really need this to pass, but we will, however, the best process for getting it into statute is if it needs to go through the budget process, because of the change in the statute, if in fact, the budget passes and the program does move over to DHHS, I understand a different statute potentially would need to be modified. So whatever, I trust that we will follow that process. We just need to, we really are asking that this process be actually put into statute. So thank you so much.
Thank you. Any questions from Ms. Minihan? Seeing none, thank you so much for your testimony.
Thank you.
I have no one else on the list of people who signed up in time to testify.
There are no hands up in the audience.
And there's no hands up. So I am going to. All right. Lucy Portney.
Good morning, Mr.
Portney.
All right, I apologize. Good morning, Mr. Chairman, members of the committee. My name is Lindsay Corney. I'm the Executive Director of the Office of Professional Licensure and Certification. I apologize I wasn't able to register on time. But OPLC is the agency that administers the Pdmp, and so I wanted to offer my support of this bill and be available to answer any questions if you have them. As previously discussed at length, Section 2 would permit the office to integrate the Pdmp with electronic health systems across the state. As Dr. Strang mentioned, one of the most cited barriers to use of the Pdmp by practitioners is that it interrupts workflow. Practitioners must at present leave the EHR to query a separate portal, which obviously takes additional time, and it's been cited as a reason for non-use of the Pdmp. By integrating the New Hampshire Pdmp with EHR systems, as other states have done across the country, New Hampshire would promote the use of Pdmp by practitioners and dispensers by eliminating this barrier and providing ease of access within an established workflow. So obviously, given the public health crisis currently impacting our state, which is the opioid epidemic that remains, OPLC supports this legislation and requests your support as well. That's all I have for comments, but I'm happy to answer any questions if you have any regarding the program or this piece of legislation.
Any questions?
Good morning.
And the meeting welcomes Representative Kendall Snow to the LOB. All right, seeing no more questions, and I am now going to close the hearing on House Bill 45, Senate Bill 45, and open an exec session on the same. Representative Marsh, you had made a suggestion about the possibility of retaining it.
Yes, my concern, Mr. Chairman, is that if we pass this bill and it's immediately repealed by one of the provisions of the budget, we will not have accomplished really very much. If we retain the bill, then the Senate certainly can add this language to the language that is going to be put into 136A as part of House Bill 2. And if that process somehow hits a roadblock or something needs to be fixed, we would immediately have this on hand as a vehicle to then put it into whichever statute the Pdmp ends up in the fall after the budget is built. And that would happen much faster than it would happen if we had introduced a new bill next fall. So I think the best thing as far as getting this in place the fastest would be for us to retain the bill at this point in time and let the Senate and the language to the budget. Representative Weber has her hand up. I did not make a motion yet.
Representative Weber.
I'm confused by the logic of Representative Marsh, so I'm just trying to untangle procedure here. It seems to me that if we decide this is a good bill, and I certainly think it is, and we pass it, all we're doing is adopting a committee recommendation. Nothing happens with the committee recommendation until the next time the House meets. at which point, which I'm told isn't going to be until for quite some time, the budget doesn't have any effect on this legislation whatsoever until the governor actually signs the budget into law. So it seems to me that there is no reason why we could not pass this, recommend this as ought to pass, send that to the House as our recommendation so that it is very clear what our position as a committee is on the legislation. If that is the committee's position, I'm making assumptions. And then at that time, we can either table it in the House if we know that it has arrived at a destination that's agreeable to everybody, or we can pass the legislation knowing that there will have to be committees of conference and other sorts of things, or that it could simply be held either by the President of the Senate or the Speaker of the House until such time as the budget had been resolved, and we would have it in reserve. So I'm wondering if it doesn't make more sense to pass it if that's the will of the committee on the action on the bill, and then allow further steps later on in the process. And I would, if I have lost sight of the ball somewhere, I would welcome somebody explaining to me how.
Representative
Folsom.
Folsom.
Sorry. Is it currently part of Part B of the budget? The answer? Yeah. Answer.
Yes. Section 39 of the budget would repeal RSA 318B 31 to 38.
That's the problem.
Which is precisely what this bill is amending.
Correct.
That was also in the governor's budget. It was not added by House.
Representative Gay.
Thank you for taking my really genuine question. If we pass it, does that mean, if we pass it here, give our recommendation, does that give leadership the choice of letting it be a standalone bill, which at this point would feel really good to know it's standalone because I don't see how anybody could be against it. And the fact that it somehow got in the budget would be irrelevant if we pass it?
The language in the budget doesn't include these new provisions.
Mm-hmm. Can we supersede it if we pass the bill separately? I mean, we have to recommend it and then it can get voted on. It can get voted on. If it passes by itself, would that automatically affect the budget?
No, because it's a different, the Pdmp is moved to a different statute. It's moved from RSA 318B to RSA 126A. So whatever amendments we make to RSA 318B go away when that section of law is repealed, and it reverts to the section that then's put in place in 126A. Representative Weber is perfectly correct. We could pass the bill and table it, but then if further changes have to be made from the fall, one of us would have to file another bill to make those changes. Whereas if we retain it, we have a vehicle that we can then immediately make whatever changes are needed. And if no changes are needed, then we can say it's unnecessary at that point. So it's really a procedural question. Representative Weber wants to comment.
Representative Weber, you may.
That was the clarification that I was looking for. And I want to clarify in turn. If we as a House and Senate pass two conflicting bills, the deciding factor is which one is signed most recently by the governor. But what I had not really fully grasped was Representative Marsh's point about having a vehicle available not so much the conflict with the budget, but having a vehicle available should a quick fix be needed, because this would carry with it the possibility, if not the reality, that we could get it done quicker than if it required a whole new bill. So his point is well taken in that respect.
Yes, Representative Folsom.
Thank you, Mr. Chair. If we retain it, is it possible for us as a committee to not take an official vote, but more of a straw poll so that we can
Highly recommend.
Highly recommend, yes, but not officially recommend, so that leadership knows what our intent is with what in retaining, or is that just something that can be verbally shared with them?
I would think it would be better verbally shared. I'm not sure, Representative Weber can help me, but I'm not sure that we actually have a device to do that.
Okay.
Well, if I may, Mr. Chairman, there's nothing to stop the chair asking for a straw poll on anything. It doesn't actually have any effect on anything. And certainly anybody from the committee is welcome to convey their thoughts and on any of our proceedings to anybody. So there's no problem with conveying it verbally. And there is no problem certainly with taking a straw poll if the chair desires to do so. But it doesn't have any effect other than we know what we did, and the clerk will have and the clerk will certainly have a record of it. So that in that respect, it might be useful.
Anybody like that idea of a straw poll? I like straw polls.
Straw polls, fine idea.
Then let us take a straw poll, which is not an official vote, but I'd like to know how many people are affirming this in the straw poll. And the straw poll is that we like this bill as it was presented to us. And in some manner or other, depending on what happens to RSA 318 and so on, we would like this to go forward. So I guess the straw poll is we like the bill. Informally, without writing it down, but using their names, I would like to have that roll call so I can, when I write a letter, say that so many people affirmed this in an unofficial straw poll and so many people didn't. So would the clerk call the roll on the straw poll that we affirm 45?
Thank you.
Thank you.
It's not a vote. I mean, it is a vote, but it's not an official
I
vote.
came in late. So far, I haven't heard. I assumed that it was 45.
Yes.
It is. It is.
Certain. Nobody had mentioned the number. So I want to be sure I was voting in the right bill.
Okay, call the roll, please.
Representative Marsh.
Yes.
Representative McMahon. Oh, he's not. Representative Nelson.
Yes.
Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey.
Yes.
Representative King.
Yes.
Representative Cofalt.
Yes.
Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Snow.
Yes.
Representative Knirk.
Yes.
Representative Soloway.
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham.
Thank you. Yes, but I'd like a little more clarification on the best way to actually get it passed. You know.
Let's finish the roll call and then we'll go back to that.
Okay, thanks.
Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Merchant.
No.
And Representative Pearson.
Yes.
Mr. Chairman.
1 second. I think that's 19 to 1.
Yes.
Representative Marsh.
Yes, with the understanding that you will write a letter to the Senate Finance Committee saying that we overwhelmingly support this language be added to the RSA 126A language in House Bill 2. I will move that we retain Senate Bill 45 so that if somehow that does not happen, we then can deal with this when we meet in the fall.
I write a letter to the Senate Finance that we want this bill's language.
The RSA 126A 89 language.
126A 89.
Yes.
If that's a motion, I will second.
Salloway would like to second that motion.
You missed your chance, Representative Sullivan. Representative McKay already did.
Okay, I'm one step previous, and that's what I have to do next. I have that. Then I heard, if the chairman is willing, and the chairman is willing, Representative Marsh moved to retain, and Representative Soloway seconded. Any further discussion?
Representative Weber, Representative Fishman, Representative Acton.
Representative Weber.
I have one point and one question. While I understand Representative Marsh's thoughts on having a vehicle available, it seems to me that this committee is surrendering a great deal of its authority if we do not choose to either pass or ITL this bill, because we are then at the mercy of what happens in the budget. And there have been times when budgets have not passed at all. And if that is true, then nothing's going to happen here either. So that's the concern I have with the proposed process. I really think that this term, the policy committees have surrendered a great deal of their authority to the budget process. And I do not think that that is good policy either now or in the future. I understand that COVID makes things much more difficult, but I think it's a bad precedent to start. The other thing is that we have not heard from Representative Merchant on why he, I beg your pardon? My second point is that we have not heard from Representative Merchant about his opposition to this bill, but given that he is intimately involved in working with the Pdmp in one way or another, I would very much want to hear his thoughts and others. We took a straw poll without hearing that, and my opinion might change based on what I hear from other members of the committee. So I want people to bear that firmly in mind, because my vote may change. We have not yet had a discussion. And again, that is a further erosion of the committee process of discussion before votes. So
I'm going to bump Representative Merchant to the top of my list of those wishing to speak, so he can speak to that very point. I was going down the same line of thinking, Madam Ranking Member. Thank you. Representative Merchant.
Thank you, Mr. Chairman. I think the bill, the intent of it is something I can support. The way the bill's written, I could not. And my rationale to that is, if you go back into line 3 and 4, where it says dispenser with medication reconciliation, that is not always done by the dispenser. Sometimes it's done by the prescriber. So therefore, I think the prescriber should have the same language in there as well as the dispenser, because there's times in which a physician will do med reconciliation, not just the pharmacist. And in that capacity, the physician is not a dispenser, they're actually a prescriber. On number 2, when you get down to line 14, a practitioner who neither prescribes or dispenses, who is not actively working as a pharmacist with a New Hampshire licensed pharmacy or a New Hampshire healthcare facility. That does not talk about a practitioner being a physician, because in that point in time, looking at somebody who works in it. But the thing is, if you don't work inside of the facility, if you're a physician and prescribing from your home, you're exempt from this, because it doesn't include the fact that you're licensed by the state It talks about where you're performing the activity, not the fact that you have access to the database when you're retired. So if you're retired as a pharmacist or a physician, you can still have access to the database, which is what we're trying to minimize and to eliminate. And if you put the fact that they have to be in a physical facility, not by the licensure, that becomes problematic. Number three, when you look at number 23 line about the query and retrieval of the database, it's not patient specific. So my concern is that the way it's written, a program can be written in such a way that's querying the whole database and pulling back and retrieval, not something that's patient specific, but pulling back a lot of the database that's not really connected to a particular patient. Number four, I think the patient should be aware of the fact that you're taking data from one database and putting into another database because they have access to the database that they want to in the prescription drug monitoring program to see whose footprints are all over their data. When it goes in electronic medical record instead of a hospital, they don't have access that way. They have to go through another process to get access to it. So for those reasons, I don't support the bill the way it's written. I could support the bill if it's modified.
Thank you. Representative Cushman.
I put my hand down. Representative Weber asked my question. Thank you.
Representative Acton.
Yes, thank you, Mr. Chair, and thank you for the time. I have to concur with Representative Weber about this. I'm very worried that by retaining, it's going to get thrown into a budget process that we have no control over at this point. And it's not looking good as far as the budget fight. And so a lot of this may wind up on the negotiating room floor. The other thing is that the need has been demonstrated by practitioners. This is a source of trouble for them. That need is now. So retaining is just another way to kind of put it off. We need more of a sense of urgency, I believe, and whatever it takes to get this done. This session now is what I'll support. Thank you.
Representative Gay.
Thank you. After listening to all of y'all come up with ideas about how to tighten the bill, I would really prefer that those be submitted in an amendment because, you know, right now we're not looking at 59 bills to look at. It seems like it would be worth doing it correctly and making it into a separate bill. Not if the budgets can come and go, line items can come and go. I also, like Lucy, pardon me, Representative, would like to see this as a standalone bill as it was submitted and support that. Whatever they want to do with the budget, they can do, but that's fluid. I'd like this to stand. So, but with the corrections in it, because we certainly don't want to break the intent by leaving out some critical words.
The chair calls on himself, and I've been wondering, and I think Representative Merchant's concerns bumped me a little forward. If language were put in through an amendment that under line 5 and wherever the number 318 appears again, if we said a licensed hospital pharmacy under RSA 318, or should 318 be abolished, 126A89, that way the bill comes out, meaning wherever you folks put this stuff, this is where we want this to go. I mean, that may be too simple to be good, but that's what I thought. And then at that point, we could on the quick, Representative Merchant and others who may be sharing your concern, offer that as part of the amendment, or there could be two committee amendments, and we will come back at some point fairly soon and address this. How does that sound to the crowd?
Mr. Chairman, I was put my hand up to very much second the comments of Representative Gay, but I will second yours as well. We've got plenty of time and we have two bills so far, so there is enough time for Representative Merchant to draft an amendment with his concerns. in it so that we can all take a good look at it. And the other thing, just for members of the committee to know, is that you're absolutely correct. The drafting staff in OLS has a great deal of expertise in drafting alternatives in their legislation, and I have sometimes seen them get quite involved, and this one doesn't need to be that involved. But in the event that this other bill passes, this happens, and in the event that this other bill fails, that happens. So I think there is room for that to happen as part of a reconciliation process, but also right there in the bill. And I certainly would be much happier waiting to see what Representative Merchant and others who might want to speak to him come up with, because I think the points that he makes are very valid, and I would like to see them examined and incorporated if that's the will of the committee.
Chair.
Representative Weber, let me come back to you on that. And do you think it would be wise for the my concern about language saying 318 or wherever PHPB lands be in his amendment as well, or would that be another amendment that I would craft?
I think that would be a subject for the people drafting to discuss with OLS, because they have more experience in doing that than I, and I generally leave those to them.
Thank you. Representative Marsh.
Mr. Chair, I would like to withdraw my motion, and I will agree to work with Representative Merchant on an amendment, and we can put contingency language in it as Representative Weber suggested.
Representative Soloway, will you withdraw your second?
Yes, Mr. Chairman, I will withdraw the second.
Thank you. And thank you to Representative Marsh on that. I will check with OLS about whether that could be or should be one or two amendments, and loop back in with Representative Merchant and Marsh, and give a few more minutes if anybody else would like to right now throw in some thoughts, knowing that you can talk with Representatives Merchant and Marsh about the big amendment. So anybody now still, before we move on to the next bill, want to weigh in?
Sounds like a good plan.
Representative Nadarapam, I had said I'd get back to you and I didn't, but here I am. So you wanted to say something a little while ago?
No, I think this is a good plan. And so my questions have been answered. And then when we get a look at the amendment, it'll be clearer how we're going to vote, retain or pass now or all that. So thank you.
Thank you. Anyone else? Last minute. Okay, then
Mr. Chair, can I just say a quick?
Oh, you beat me by about 4.5 inches. Go.
Okay, good. I just want to quickly go back to, and thank you, by the way, Mr. Chair. I just want to go quickly back to what Senator Guy mentioned about at some point we need to put reliance upon the belief that the practitioners are going to do the right thing. I think too many times when we're in government, we may be jaded because we happen to see a lot of problems and so forth, that we tend to start perseverating too much on the wrongdoers, and we forget that the vast majority of people who do the right thing are wind up getting inconvenienced because we're building in so many regulations and rules to go after that tiny percentage that may want to take advantage of this. So I just wanted to call attention to that and just remind people of that. Thank you.
Thank you. Okay, with that, the totally blanked the term. Exec session on Senate Bill 45 has come to a close. And now I open the hearing on Senate Bill 120 relative to physician assistant medical services through the Manchester Veterans Administration Medical Center. And we have Senator Sherman as the prime sponsor. And Senator Sherman, you may proceed.
Thank you, Mr. Chair. Can you hear me?
Yes.
Awesome. Thank you, Mr. Chairman, and hello to my friends in the Committee on Health and Human Services. I always feel like I'm coming home when I'm in front
That's
of you.
because you've been here before.
Yes, I have. So for the record, my name is Senator Tom Sherman, District 24, representing 11 towns on the seacoast. And I am introducing SB 120. This is a bill that was requested by physician assistants, and I believe Linda Martino is here to testify, and she can speak in more detail to this. I did want to basically outline the rationale behind this, and that's that in the statute, which is 328 D2A, there was not the clear provision that New Hampshire physician assistants, in other words, physician assistants licensed in New Hampshire, can work under physicians from elsewhere who are at and employed by the VA in Manchester, or the VA, the Veterans Administration Medical Center. So that was the point of the bill, was to make it possible for physician assistants to practice at the VA under, PAs have to work under the supervision of a physician, but as we all know, the truth is that there are many physicians at the VA who are not credentialed in New Hampshire. So that was the point of this, was to allow New Hampshire physician assistants to work under those physicians. There has been some confusion because the original bill, the statute, if you look at line 8, it says New Hampshire, well, line 7 and 8 says New Hampshire state licensure laws, rules, and regulations for physician assistants are hereby suspended for those physician assistants from other states or countries who are employed, and then it keeps going. That's current existing statute. In the bill as introduced, I had inadvertently struck out "or countries." When it was coming to the floor of the Senate after having been approved with, by the committee with unanimous support, the PAs and VA recognized that that should not have been stricken because it actually is pre-existing statute. And I've gotten a couple of emails from members of the committee, from your committee, on this. I just wanted to tell you where this came from. So the floor amendment reinstated the original statutory language. I don't have a strong opinion on whether or not that's appropriate, but what we did was just reestablish the current statute. So with that, I am happy to answer any questions I can on the bill, and I believe Linda is here and she can speak specifically to the PA role at the VA. I guess that makes them VA PAs, but anyway.
It's okay with me.
Yeah.
I have a question. I know there are similarities and differences between PAs and nurse practitioners. I employ 2 nurse practitioners, no physician's assistants, but my eye doctor employs 2 PAs and no nurse practitioners. So
right.
In our conversation, we compare and contrast. Would you be amenable to adding nurse practitioners to physician assistants?
Well, thank you for the question. Technically in New Hampshire, that would not be necessary because nurse practitioners are allowed to practice independently.
Okay, that's
PAs are not. So it's not an intentional, well, it is an intentional exclusion because they don't need this. Nurse practitioners in New Hampshire have the right to practice independently and do not have to be under the supervision of a physician, which is one of the, they have different training, and I would be clobbered by my favorite nurse practitioners if I said they're very similar. So I won't say that. And also by my favorite PAs. They have different scopes of practice. They have different roles. As patients, we see them, doing sort of the same things in many cases, but actually, unless you have a physician in your practice, Mr. Chair, you would not be able to have a PA practicing, because they have to have an identified physician supervisor. So I have a PA who works under me and I'm her identified supervisor. But my nurse practitioner does not need any of that. She is independent, can practice on her own, and she's overseen by the Board of Nursing.
Thank you for reminding me of that. My second question to you is, I see an amendment put by Representatives Knurk and Marsh, Amendment 1107H. It seems to me that the difference is in line 15 of the bill, the word "or countries" is struck. It's not in the amendment. And in line 20, the same thing. However, if you go up into line 8 in the amendment, "or countries" still appears. So either that is for a reason that I can't figure out, or they got 2/3 of the references to countries out.
So the difference between those lines 8 and lines 16 and 22 is that 16 and 22 are referring to the supervising physicians.
Okay.
And line 8 is referring to the actual physician assistants. I would just caution the committee, and I don't have a strong feeling on this, but I would defer to the VA on whether this is going to impede what they're trying to do, because as we all know, workforce in healthcare is in some level of crisis, and so I don't know if they have physicians from other countries who are working. I know they do have physicians from other countries working in their practices. I think the difference here is whether they have a U.S. license. So I have many colleagues in the medical field who are really quite outstanding physicians who attended medical school, did their residency and other training abroad, came to the United States. They are among the top in their field, either at Harvard or Duke or Barnes or any of the wonderful hospitals, but they are licensed to practice in the United States. So the only question I would defer to the VA on this. I think we don't want to be limiting physicians by their country or state of origin as much as we would want to be sure they have a U.S. license. And that's what's highly regulated in terms of their competency. So, and also, by the way, not just competency, but their ongoing monitoring, because we are one of the most highly monitored occupations, I think, that there is, probably next to airline pilots. So I would, on that question, on that amendment, I would just caution to make sure if there's going to be a change that we're not blocking supervision by out-of-country physicians, but we want those physicians that are supervising to be licensed in the United States, not that they have to be from the United States. So anyway, that's my only comment, and I would defer to the VA, the people from the VA, as to the exact wording here, and whether, as far as I know right now, they have no out-of-country physicians on their staff, but it would be better to ask them that.
Thank you very much. Any other questions for Senator Sherman?
Representative Burke.
Representative Merchant.
Thank you, Mr. Chair, and thank you, Senator, for taking my question. I concur with the issue of having licensure within the U.S. versus the country in which they reside. And following that theme, would it be logical then for a physician assistant to also be licensed by New Hampshire or a state within the United States, if you will? Back to the same concern is that we have a standard of care, which is what licensing board creates. And therefore, if a physician assistant wanted to be practicing in New Hampshire, in, if you will, within the United States, if they would be required to have a license by a state agency in one of the states, regardless of the country they come from. It's not so much a question of where the residence is and what country they're from, but do they actually, in fact, hold a legitimate license to practice here in New Hampshire, the United States?
Thank you for the question. As I mentioned in my little introduction, that is currently in statute. So I was asked to reinstate it with my floor amendment. So I agree with you, though, that the key, again, not only to setting a level of competency, which is licensure, whether it's nursing or physicians or PAs, but also being able to monitor. One of the things we learned in Exeter back with the hepatitis C outbreak is that if you don't monitor somebody, you can't keep track of bad behavior. And that's why we established the only board of registry of medical technicians in the country, because the guy who was at Exeter had been to 16 other facilities before he came and did his dastardly deed on our hospital. So so I think licensure in the U.S. for anybody practicing in the U.S., unless there's a compelling argument against that, is something that I would be in favor of, because it really allows us that ongoing monitoring as well as setting a basic level of competency.
Representative Gay.
Thank you, and thank you for taking my question. As a non-medical professional person, I'm just looking at the wording, and in the original bill, line 15, it talks about, when it says a person's from another country, to me, that doesn't say anything about their licensure or their presence. So when it says provided they possess a current license in good standing in their respective state or country, I thought a doctor to practice here had to be licensed here. That's question A.
Why don't we let question A be answered first?
Okay.
Right?
The same
Go
wording
ahead,
is
Senator
multiple
Sherman,
places.
on that question.
So it's my understanding that within the Veterans Administration system, because they have so much flux, that they are typically, you have to have a license to practice, as is mentioned here, but it does not necessarily, because it's a federal program, you do not necessarily have to have a license. I would have to check this, but you do not have to have a license in the state in which your VA is, where your VA is. It's sort of like more of a national program. You do have to be licensed to practice medicine. But it's my understanding that it doesn't necessarily have to be the state of New Hampshire. If you look at that existing statute, New Hampshire state licensure laws, rules, and regulations are suspended. Now that's physician assistants. I'd have to go back and look at the statute for providers, whether it's nurse practitioners or physicians. But you do have to still be licensed. So I don't know if that really answers your question. I don't have a full answer on how they handle physicians in the VA system, but they do have to be licensed.
Hello?
Follow-up.
I'm wondering if there are VA hospitals all around the world, in which case you would you could be employing doctors from, or medical care people from that country. which could be spelled out here because I'm surprised, the bill doesn't say exactly everything. But I would think that they would have to be licensed where they are practicing. Does and certainly if they're from another country, that doesn't, that seems immaterial. Are they licensed to practice where they are? And that would, if it said that, it would cover medical facilities around the world.
Right.
I'm just concerned about where they're licensed because it appears multiple places in the bill.
Right. Remember this, thank you for the question. This bill is only about physician assistants. This is not dealing with licensure for physicians or nurse practitioners. So it's trying to address the issue of New Hampshire PAs who want to practice at the VA, and because of the structure of the VA, they have physicians from other states and apparently other countries, although I've been told they don't have any currently. And so a PA cannot practice in the state of New Hampshire without having a physician supervisor. So that's the entire intent of the bill. We are not trying to go into the VA rules and regulations and the New Hampshire statutes that work with the VA when it comes to providers like nurse practitioners or physicians. You raise a good question about what are those rules and regs, but some of it is federal because the VA is a federal system. And some of it is how New Hampshire has adapted to allow the VA to continue in Manchester. And one of the things that I would also say is that our goal here is to make it easier for our veterans to access the care they need. That's the goal. And the way this bill makes that easier is by allowing our PAs to practice at the Manchester VA and their facilities. That's all this is intended to do. It's not trying to change existing statute. It's just trying to make sure that New Hampshire PAs can practice under the supervision of a VA doctor.
Thank you, Senator Sherman. Is there anyone else who has not asked a couple of questions who would like to ask a question? Representative Weber. Representative Weber.
Thank you. Just so we're clear, we have before us a bill with some changes on line 15, 16 that we've been discussing, and 20 and 21 that we've been discussing. And we also have an amendment that changes some of that language. And am I correct in understanding that the bill as it was brought to us would allow the supervising physician to be licensed either in any state in the United States or in another country, and that is as the language of the statute is now anyway. And the amendment would restrict licensing only to those, restrict supervision only to those physicians who have a license somewhere in the United States. Is that a fair assessment of where we are right now?
I do not have a copy of the amendment, so
okay.
I apologize. My concern from whoever was reading the amendment earlier was that it didn't do that. My concern was that what it did was it said that physicians from other countries
Follow up, Mr. Chairman?
could not, and that would be a problem. If it's limiting licensure to U.S., they have to have a U.S. license. Remember, what you're doing in this is, and it's fine because you're restricting it to PAs, but I would be cautious about limiting what physicians can practice or which physicians can practice at the VA. All you're doing here, if you have this amendment, as I'm hoping it's written, I see Representative Knirk looking like it probably does just limit it to licensure in the United States. If that's what it does, it's saying that if you have a PA from New Hampshire that wants to practice at the VA, that PA can be monitored, can be supervised by a physician either from the United States or another country, but they have to have a US license.
Might I just read you the language?
I
Up to the
would like to do something that I did once before, and that is actually call upon the person who is the prime of the amendment. And Representative Weber, I'll circle back around, but Representative Knurk, could you please clarify your intent in the amendment?
And Dr. Woods has this.
Yeah, yes, because I did want to speak, but since I was testifying, I couldn't speak or ask a question. So first, important to understand that the amendment does not affect people who just happen to come from another country. Indeed, we have an enormous number of foreign-born graduates who work in this country. It has to do with just licensure. And what it says in the current statute, 328D2A, it says New Hampshire state licensure laws, regulations for physician's assistants are hereby suspended for those physician assistants from other states or countries. It never says physicians.
Right.
So when they ask it to be put in the other language from the statute and the word physicians from other countries, that does not exist in the statute. The issue was that it had to cover out of country physician assistants because there are some of those who are in existence. I don't know if they're currently employed. So the point is, this amendment does not bring back the current statutory language. What it does, for example, let's say you are from England and you are going to be working in the VA system, but you're going to be licensed in this country where your license is going to come from a state. And you will not get, for example, a license in the state of Massachusetts unless you were residing there when you applied for it. So that's why when you say from another state, that person from Massachusetts can come up and work at the VA with no problem because they are licensed in the state of Massachusetts. The fact they're born in another country has nothing to do with what we're talking about. We're not talking about birthplace, but licensure. Basically what had happened is when I read this, it caught my eye. Bill Marsh and I were both sponsors, co-sponsors, and the language wasn't in what we signed off on. And that's when I found out it was supposedly to add this language from the statute in, but I put the original bill and the statute and all this up in the computer, and I kept going back and forth, and it just simply doesn't exist about out-of-country physicians. It's out-of-country physician assistants. So anyway, the point is, if you look at the wording on the amendment, it simply takes out in line 15, physicians from other countries. Well, actually, you look at the whole sentence. Physicians from other states or countries, provided they possess a current license in good standing in their respective state or country. Because the way it was written, a person licensed just to practice only in, let us say, South Africa, but not licensed at all in the United States, would be able to supervise one of the PAs. That's what a strict reading would say. As it is now, that person could be born in South Africa, trained in South Africa, moved to the United States, licensed in the state of Virginia, is now transferred up to work at the VA in New Hampshire, perfectly able to do that because they're licensed in a U.S. state. So that's all it does is I think it clarifies that, and I personally don't think it makes it confusing, but if indeed our grammatical coaches, Representative Weber, feel that it still is not clear, then we might want to redraft it to make certain that it says that it doesn't preclude a person born out of the country. But again, because you can't get a licensure in this country without having at least resided here for a while, I think that's not a problem. And so the second part there in line 20, again, just gets out of the word out-of-country physicians, because again, it's referring to licensure. It's not referring to where they're born. And yeah, I'll take questions, obviously.
Well, not yet. You were not quite. You jumped.
No problem. I just want to say that the goal is to make it work. I'm not wedded to this language. If it's not right, fix it.
Okay.
Could I just comment on the amendment then?
Yes, Senator Sherman.
So I would ask Representative Knurk to make sure that he has looked at existing statute for VA physicians practice, which just to make sure that this does not run afoul of what we allow the VA to have. In other words, I would check with the VA and check with statute to make sure this doesn't have unintended consequences for anybody. But I agree with I don't have a problem with the intent of this, and I do agree that I think it's important that our PAs are supervised by people who have licenses in the United States.
May I answer to that? I will say that I checked with Linda Martino, who is going to be seeking, and Richard Laflamme. They are the PAs and the people from the VA who are involved in this, because I did multiple emails back and forth, and they were in agreement that this part regarding out-of-country physicians could be struck. But let's hear it straight from them before, not processed through me. They'll be coming up. I know that they're listed on the testifying list as well. Thank you.
All right, I'm going to circle back as promised to Representative Weber.
Thank you, Mr. Chairman. And I just wanted to say that I think the reason I wanted to read the language to Senator Sherman is that I think that the language says much more clearly and in many fewer words exactly what Representative Clark just explained to us. And I also wanted to let Representative Sherman know that I have taken a photograph of the amendment. And
I got it. Thank you.
And I've also asked committee services to email you a copy, so you shall soon be inundated with copies of Amendment 1107H.
But the language as drafted in the amendment says may be supervised by physicians. And here is the problem that might come up, because it says from other states, and we don't care where they're from, we care where they're licensed. The second half says, provided they possess a current license in good standing in their respective state. So we may need to remove the words from other states, because as has been said a number of times, we don't care where they're from. They could be from anywhere, provided they have a license in good standing in one of the other United States, as opposed to anywhere else. So I think there may be room for a little more work, but I think we're getting close.
Yeah, the only other comment I'd make on that is, and I'd have to think this through, is whether that actually has to read may be supervised by physicians from New Hampshire or other states, because we don't want it to exclude, although the may allow it to exist for New Hampshire, but you don't want to say, well, they can't be supervised by a physician from New Hampshire because it says only from other states. So I'm just...
Follow up, Mr. Chairman?
Yes, please.
If instead of saying by physicians from other states, which then might arguably preclude physicians from other countries, if we said by physicians not licensed in New Hampshire, because it's the license that we care about, not where they're from, may be supervised by physicians not licensed in New Hampshire, provided they possess a current license in good standing from one of the United States, or however we want to.
I think that sounds good, and it could be it could stay in their respective state. Right. But however you wanted to do.
Well, we want to make it clear that they've got to have a license from somewhere in the United States. That's
right.
What
yep.
We're about. Thank you.
I have another question about this.
Excuse me, Representative Woods is up next.
Thank you, Mr. Chair, and thank you, Senator Sherman. Good to see you. Had actually several questions, some of which have been answered. I just going through from my first question was in the first line, line 5 on the amended Senate bill. Is New Hampshire state licensure laws, rules, and regulations for physician assistants. The way I read it, and I'm not an attorney, that would seem that would suspend any licensure laws, suspend any rules, would suspend any regulations. My sense that it should read, because we're only dealing with licensure, that the New Hampshire state laws regarding, New Hampshire state laws, rules, and regulations regarding licensure. Because otherwise it seems like it would read that they would be not subject to the Board of Medicine's other, besides licensing, that wouldn't be subjected to the rules and regulations as promulgated by the Board of Medicine, which, and again, I may be, I'm not an attorney, and it may read perfectly fine right now. I have, secondly, I have concerns about this issue of licensure and supervising from a distance. The whole concept, at least as I understand it, was that there was some kind of cooperative and collaborative, I think is the correct RSA term, activity. In other words, when I was in practice, we had PAs in the office, and if there was a difficulty, and just like I'm sure Senator or Representative Marsh, if there's a question comes up, they're right there. We can collaborate and formulate a plan. I have concerns about being at a distance and what that means. If it's something that occurs at 3 in the morning, am I going to call somebody in Arizona? I don't know that that really works very well. So I understand, and I understand the need, and I understand the intent, and I really would like to work such that we can do that. I'm not too sure the way it's formulated and the way it's worded right now that it accomplishes that. I do have concerns that this is also a situation that could be a precedent. It's let's pretend and read the RSA instead of the VA as convenient MD. What would we do that for convenient MD?
Now, if I could just jump to your second question first. Sure. The intent here is not to have telesupervision. These are physicians practicing at the Manchester VA, is my understanding, who are overseeing, so they are actually practicing at the VA. They don't practice outside the VA, and they do not have a New Hampshire license. They have a license in another state because the VA system, as I mentioned earlier, is a federal system. So this would not be somebody supervising a PA from Arizona. This would be somebody who has an Arizona license practicing at the VA in Manchester and directly supervising the PA.
Okay,
so
that may be I'm not reading it correctly then. The way I read it is that they could be elsewhere.
No, it's not. It has nothing to do with site or site of origin or any telemedicine or telesupervision. I think that would be setting a huge precedent for PAs.
Okay.
And that
should
would
be stated.
Well, I leave that up to the committee. I don't think it needs to be stated because it was certainly never, I don't see that as being allowed. But we'd have to go into VA rules and regs and all that kind of stuff. But my understanding is that this is direct supervision, which is the standard of practice for PAs, certainly in New Hampshire. And if the committee feels that that needs to be specified, I'm absolutely fine with that, because I agree with you, Representative Woods, that we're not embarking on telesupervision. The second one is 7 through 9 is existing statute. It's beyond the scope of the intent of the bill and the actual bill to try to rewrite existing statute. This was to make it possible. The single goal of this bill was to make it possible for PAs from New Hampshire to be working at the VA under the supervision of a non-New Hampshire physician. That's the goal. And so if I think you could have mission creep if you try to get into that, because you would have to be absolutely sure that you are not impacting current standards of practice at the VA. But I hear your concern, but it is not within the goal of this bill to impact that first part of chapter.
Thank you.
Thank you, Representative Woods. Next up on my list is Representative Shapiro.
Thank you, Mr. Chairman, and I apologize for interrupting before. I understand that the term "and out of state" is already in statute, or there's some question about whether it is or not, but I'm wondering if out of state would preclude people who were not in another state but were licensed in the United States, like Puerto Rico or Washington, D.C.
That's a really good question.
Yes.
So maybe state or territory would be more inclusive. And I see Representative Knirk got his red pen out, so.
Yeah, follow up. Because it does say in other states. However, on line 19, it says out of state. So out of state could include those territories, but in another state would not include those territories.
I love this committee. You guys find stuff. You just make bills better, so thank you.
Representative Nelson.
My question was just answered about using the word states. So we're all set. Thank you.
Anyone else who hasn't asked a question? Representative Snow, unmuted. Representative Snow.
That would be an inappropriate question, but in as much as we have Senator Sherman on the line, I wanted to bring up a concern that has just risen since last week on a bill that this committee passed last year. The Senate signed it and the governor signed it. And I'm muddying the waters by bringing in a bill that's not part of this public hearing. But I need to be sure I have an
Senator Snow, I want to hear that, and I think it's going to be important, but can we push you back in the line?
Absolutely.
All right, so I'm writing your name here. It is not a prayer request for precipitation. It is a reminder to me to make sure you get to do that. Anyone else who has not asked a question of the senator? Okay, Representative Gay, one more.
Okay, thank you. Thank you for clarifying the whole goal of this, since we've talked about many details. I want to make sure, I will state what I think the goal of this is, of this bill and amendment, and please correct it if it's not right. To me, the goal is to allow hiring PAs from other states or countries so that they can work under at anywhere in the VA, coordinated through the Veterans VAMC, work under the direct supervision of a doctor who is certified to work for the VA. I'm trying to circumvent state law versus federal law on recognizing the physician. But the whole goal is to allow us to hire more PAs who are not licensed in this state, but they are licensed, well, not even quite sure where they're licensed, but they would work under a licensed physician who is appropriately credentialed to work in the VA.
Thank you for the question. The answer is it is already allowed for a PA in lines 7 through 9 in existing statute for PAs from other states or countries to work in New Hampshire. What is not currently allowed based on New Hampshire statute is for New Hampshire licensed PAs to work under the supervision of physicians who do not have a New Hampshire license. And the only place in the state that I know of where this would apply is at the VA. So New Hampshire PAs who want to practice at the VA currently can only practice under a provider, under a physician who has a New Hampshire license. And what this bill does is, and that there's a possibility that no one working at the VA would fit that description. Because the VA is a federal system and their physicians are licensed, as we've been discussing, but they may not be licensed in the state in which they're practicing. So, because it's a federal system. So what that means is that in this setting, the PAs covered under the bill are New Hampshire licensed PAs. They have to identify a supervising physician. And this bill makes it possible for them to work at the VA, taking care of our New Hampshire veterans under the supervision of a VA physician who may not have a New Hampshire license. That's all the bill does. So it doesn't address PAs from out of state. That's already in statute.
Thank you, Senator, and thank you for your testimony and answering these questions. The chair now recognizes Linda Martino, or should I say Linda Martino, PA.
Linda Martino is just fine. Yes, I am a PA.
Okay.
Good morning, Chairman Pearson and committee members. I thank you very much for allowing me to speak today. As I mentioned, I'm Linda Martino. I'm also a member of the board of the New Hampshire Society PAs, and I'm also a council member of the New Hampshire Medical Society. Both organizations and I are in support of SB 120, which Senator Sherman succinctly put that really just increases the access of care for veterans by allowing more PAs to help. I would like to acknowledge, and my comment to that is brief because I have a colleague that will be speaking after me. His name is Richard Laflamme. He's an active service member, and he can answer your questions based on his experience. And I just want to acknowledge today that we have PA students that are in attendance at this hearing, watching our legislators in action today. So thank you all for your time, and I defer questions to my colleague, Richard Laflamme.
And thank you, Ms. Martino. And now the chair calls Richard Laflamme, PA.
Sorry about that. Can you hear my voice at this point?
Yes.
All right, thank you. Again, my name is Richard Laflamme. I'm a physician assistant. I'm employed by the Veterans Administration. I'm a military PA, part of the New Hampshire Army National Guard, where I carry the rank of major. I'm here representing myself in neither of those agencies officially. And I want to thank the legislators and our sponsors for hearing this important issue. And I've heard a lot of very vigorous discussion, and I appreciate the thoughtfulness of our legislators as they poured over every word to make sure that this is right. And I am one of the people for which this board will have, or the impact of this legislation will have direct effect in my life. In that, I work for the home-based primary care program. I go and see veterans in their home. My medical director, Dr. Joseph Leinert, has also offered his support for this legislation. And this morning I forwarded an email to Dr. Kirk and Sherman voicing that concern. He currently represents 25% of all of the PAs that work at the Manchester VA, and he is licensed in Maine. So while he is our medical director, as it has been pointed out, he cannot serve as my direct supervising physician. And for both an administrative function as well as just the clarity of having that direct collaborative agreement with the physician who's in the best position to help me manage our veterans at home. I really do appreciate the leadership to identify this gap and to potentially close it using these documents. I agree that the scope and scale of it is limited to what we were intending, to allow my boss, for example, to supervise me directly, to meet the Board of Medicine requirements. I value the collaboration, and I think instead of having to find other physicians from outside of other departments who happen to be licensed in New Hampshire, we find ourselves meeting the law, but more the spirit of it, rather than that actual collaborative agreement, what more accurately reflects my practice. So thank you so much for creating this forum and allowing me to participate. I would be happy to answer any specific question about my practice in the VA to assuage any other fears that may not have been addressed so far.
Any questions from Major Laflamme? Representative Merchant.
Thank you, Mr. Chairman, and thank you for taking my question, Mr. Laflamme. As far as working in the VA system, it's my understanding, hopefully you can clarify this for me, that in order to work in the VA system, you have to have a license issued by a state or a territory within the United States or the confines of the US. So therefore, if I'm licensed in New Hampshire, I could practice in the VA system in California, Hawaii, wherever else I wanted to. I think it's the same with a physician assistant. So that's the question before you is, when you're in the VA system, do you in fact have to have a license issued by a state or territory in the US?
That's absolutely true. In some cases, what people will do is they'll find the most expeditious license, if you will, the easiest one to maintain, or one that was more in keeping with what they were hoping for with minimal administrative burdens. And as a result, we may have more physician assistants that are here and working, but just have not elected to use the New Hampshire licensure because of some of these cumbersome requirements for supervising agreements. You are 100% correct that, and the federal government is both in the military and as well as in the VA, very, very strict in their credentialing. It's exhaustive. Every year we go through it, we dread it. There's a lot of checks and balances, but they only work within that federal system. And if they were to leave that or to seek employment outside of the VA as perhaps moonlighting or whatever else, they would have to pursue that New Hampshire license. And as has been pointed out by colleagues today, this is only to work within that federal system. The one other little caveat would be there are other federal organizations like the prison system that could potentially hire a PA, but that's not currently true. So I can say that this is a fairly limited scope and scale, but again, a New Hampshire PA might go work in a different VA outside of New Hampshire and would be able to maintain their work in that new VA facility, be it in Arizona, while using a New Hampshire license because of the rules of working at a federal system. So you're right, you have to have a license in a state or territory in order to function. There are not facilities outside of the country that are not specifically designed to meet the needs of veterans. It did just have some future-proofed language regarding perhaps PAs that may someday will be trained out of country, but they would still have to be licensed in a state or territory in order to gain employment. Those rules are are updated periodically, but there has been absolutely no change. And as has been pointed out, it is not a reflection of any changes in scope or scale of practice or telemedicine. It is simply a measure of maintaining New Hampshire's licensure and wanting to be not only in compliance with those regulations, but actually have supervisory agreements that make the most sense by having the right physician who knows the PA able to supervise them in that federal setting. Thank you for your question.
Follow up, Mr. Chair.
Follow up.
If I may. So fundamentally, if I look at this law, what we're trying to do is allow for treatment of the veterans as if they were in the physical facility of the veteran facility, but coordinated home care. So they're not being seen inside of a federal facility. They're being seen at home or underneath the coordination of the federal system, but the practice location of the practice setting itself is outside of the federal system. So therefore, once we step outside of the federal system, we then come under the state regulations. So this allows for the VA to coordinate activity that's within the state purview that's under the federal system as far as overseeing it. Is that kind of what we're trying to get to?
I think that's right. I think the other piece is that, of course, we have these community-based outreach clinic, the CBOX. So it broadens some of that. Not all veteran care is Manchester VA, but it all happens under the purview of the federal government in CBOX, and in some cases, the homes.
Thank you.
Thank you.
CBOX.
The chair recognizes Representative Acton.
Thank you, Mr. Chair, and thank you, Mr. Laflamme, for taking my question. I just want to briefly ask you more of a general question for those of us who are newer on the committee or aren't medically trained. Can you give us some insight into the level of granularity of the supervisory relationship that you have with your physician? Is it done remotely? Do you have to pre-approve things? How much autonomy do you have in your medical practice?
That's a very good question, and I appreciate it. It is a topic that's probably a little bit different for different PAs, and some of that is based upon your degree of experience and what your supervising physician has outlined for you. There are collaborative agreements that are there that says these are the things that I'm comfortable with. These are things that I would like you to reach out for. In our particular case, well, my supervising physician resides in Maine. He has an office down at the Brady Sullivan in Manchester, and he supervises several PAs and nurse practitioners. And he is always available, and there's always one of us that's covering for this patient panel. In my particular case, there are about 40 patients that are around, say, Tilton, that he helps collaborate with me for their care. We have weekly meetings in a multidisciplinary setting where the social workers, the nurses, and the physician all collaborate on the care of our veterans to make sure they're getting the resources that they need. I may go independently into their home to examine them, but he would, of course, always be aware of what's happening because all of my notes are sent to him for both counter signature. And while I'm fully licensed within the state to prescribe medication, offer diagnoses, in the sense of collaboration that on the day when I'm not working, he needs to be informed as to what's happening. And I also assist with his patients. So it is very much a team sport as medicine is off practice anywhere else. The degree to which my supervisor feels that he needs to, or she might need to influence my care or to change what I've done would be done on a case-by-case basis based on the clinical progress of a patient. It would be highly unusual that there would be anything that's happening by one of the PAs that wasn't immediately available or noticeable to the supervising physician. We have electronic charts. They all sign off on the same thing. And we have lots of team members that go in as part of home-based primary care. We're sort of a medical strike team. So that collaboration is not just happening from the PAs, but the social workers and the psychologist or the pharmacist or the nursing staff, all of which we meet together and review weekly the care of our patients. I hope that answers your questions. There's a degree of autonomy that comes with years of experience and confidence and a strong relationship with your supervising provider. And that could all change if your patient's doing significantly better or significantly worse. But it's really based on the actual care that's needed.
Okay, that's excellent information. Thank you very much.
A pleasure.
Any other questions? Any questions?
Representative Merchant still doesn't see him.
Representative Merchant, is this an old hand or a new hand?
That's an old hand.
All right, thank you. Representative Gay.
Thank you, Mr. Chairman. And thank you, Major Laflamme, for taking my question.
Yes, ma'am.
Okay, I'm concerned. You have been really filling us in. It's great information. I don't know if you have, I guess you don't have a copy of the amendment. Excuse me. But now, because you were mentioning something that sounded like CBOX, I'm concerned to get the wording exactly right that says who we are describing. The current wording says, let's see, I'll get in the middle of the sentence because it's so long.
I think you're speaking of line 8, ma'am, if I'm correct. We were talking about patient service through out of Manchester, and now it says coordinated through the Veterans Administration Medical Center.
Yes, VAMC at licensed medical facilities, which you are not working at, outside of the Manchester VAMC. So what is the exact way to copy this, to call the service area that you're working in so that it's accurate?
Yeah, when we sat down and went over that language, it was felt, because again, some of this language was original to the RSA and how it was defined in the original exemptions for the PAs that worked at the Manchester VA. It was felt that coordinated through the VAMC represented the most accurate and simplified language because it allowed recognition that there is both a robust care in the community and that some of the care of our veterans, importantly, as we do not have a full service medical treatment facility, is often done in the community and it's done collaboratively. We may ask for consult that happens in the community and then return to us for ongoing care. But this was simplified language that instead of it just implying it only took place at the Manchester campus, but rather coordinated through the Veterans Administration's Medical Center. It is, as an employee, that is clear to me, but if it is not clear to you, then perhaps maybe that should be readdressed.
Would it be accurate to say coordinated through, but not at licensed medical facilities outside the Manchester VAMC?
I can see your point, and I would think that would be fine to remove that licensed medical facilities and just use the language or the facilities of the Manchester or the Department of Veteran Affairs in the state of New Hampshire, something that's a little bit more inclusive. That makes sense.
Thank you.
Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. Just out of curiosity, if a situation were to arise about a particular PA, their standard of care or a problem in their care, who would have the ultimate responsibility in that regard? The VA system, or would they be subject to the Board of Medicine?
I think that's a great question, and the short answer is both, sir. The Board of Medicine, I've since graduating in 2007, have always been licensed in New Hampshire, both at work at Concord Hospital and throughout my other work, and now through the VA. Well, I have a additional employer, and I have their standard of care, and fortunately a very robust system at the VA where veterans and others can raise concerns and have those concerns addressed through their professional development. I remain fully subject to the New Hampshire Board of Medicine for any corrective action, any gaps in my care, or if a patient had a concern, it would be addressed as it would be for any other PA that is licensed in New Hampshire. The only difference in this particular case, if this exception was granted, was that my supervising physician, who happens to be licensed in Maine, would also have to answer any concern raised by the Board of Medicine regarding his PA's scope or scale of practice. And I feel like it should be that way. Those agencies are designed to, again, well, they create many regulations. They're designed to address those rare individuals that do not follow standardized professional practice. And I'm glad that they're there to guide care and to protect the patients.
Thank you.
Thank you, sir.
Any other questions for Major Laflamme? Seeing none, thank you, Major. Appreciate your testimony.
An honor to be part of you.
Mr. Chair, then may I speak for a moment?
Well, I was going to get in the other member who has signed up from the state.
Oh, I'm sorry. My apologies.
Committee, and then I'll give you last at bats. The chair recognizes Kevin Grady from the State Veterans Advisory Committee.
Thank you, Mr. Chairman. Can you hear me okay?
Very well. Very good. Excuse me.
Thank you, Mr. Chairman, distinguished members of the committee. For the record, my name is Kevin Grady. I'm a 23-year resident of Hooksett, New Hampshire, after a 25-year career serving in our Air Force. Today, I'm here representing the State Veterans Advisory Committee, and we are a committee of veteran organizations whose names would be familiar to you, like the American Legion and the Veterans of Foreign Wars. I personally represent the Air Force Association, but we're chartered by State RSA 110 to essentially speak for the veteran community. And one of the things that we do is we review all of the bills that are coming before the legislature. We pick out the ones that we think have veteran impact, and then we discuss them and take a position on them, and I come and tell you what our position is. I will tell you that our members unanimously support this bill. And as I've listened to the conversation so far this morning, I want to give you just a very brief history lesson and maybe something that's going to happen in the future sometime, I hope, to sort of give some perspective to the decisions that you're making on this particular bill. Early in the morning of the 19th of July of 2017, a pipe burst at the Manchester VA, and it flooded the surgical suite there. And at the time, Governor Sununu went to the VA Manchester director, whose name was Al Montoya, and he said, "Al, what can I do for you?" And Al said, rather than me having to reschedule surgeries that are set up for veterans, you know, at White River Junction, or having these people have to go down to Jamaica Plain down in Boston, what if I got together with another hospital here locally and we sort of extended the VA privileges into that hospital, and we'll let the lawyers figure out where all the liabilities and everything were. So they partnered an agreement with Catholic Medical Center, and they used their surgical suite while the VA Medical Center was being repaired. And the governor signed that executive order. And then we thought, well, you know what? We need to codify this into the existing RSA. So in the next legislative session in 2018, you had House Bill 1273 that sort of allowed for some of the things you're talking about in this bill, people being supervised at different places within the VA system, but not necessarily in the VA. And I think that this bill goes a long way to trying to get all of the things that are included in all of these scenarios. What I want you to consider for the future is that you know, as Senator Sherman said, we're all interested in getting the care that our veterans deserve, you know, and making it easy for them to get that care. New Hampshire is the only state in the union that does not have a full service VA hospital. You know, we have a Veterans Choice Program, which was put together under the Obama administration and then was renewed under the Trump administration, that allows some of our veterans to get some services in the local community. And we think that's a great step forward. But ultimately, I don't think we're going to see a full service VA system or VA medical center in our lifetime here necessarily in New Hampshire. But the idea is, if we could find some doctors and some PAs maybe that love to ski and want to live in the North Country, and we could get an arrangement with Memorial Hospital up in North Conway, where they essentially have an office up there. It would be an extension of the VA out into places where a veteran wouldn't have to drive 2 hours to Manchester for something. You know, that's sort of the direction that we would ultimately like all of this to go. And I'm not a doctor. I don't play one on TV, and I wasn't an English major at the Air Force Academy. So I will leave the language of all this stuff up to you folks. But our vision for the future is, you know, if we can't get a full VA service hospital here in New Hampshire, we would love to be able to get the care closer to where the veterans actually are. And if that means assigning people within the VA system who tend to move around some, just like our members of the military move around some, you know, if we can eliminate some of the licensing requirement issues, as long as they're part of the VA system writ large, we think that works well. And that's all I wanted to tell you all, subject to any of your questions.
Thank you. Is it Colonel Grady?
Yes, sir.
Got it. Any questions for Colonel Grady?
No, that was.
I have a feeling we're going to see you back with some more good legislation about the VA coming in the years ahead. Thank you so much for your testimony, Colonel.
Yes, sir.
And now, Representative Knerr.
I thought I saw Fran had her hand up to ask a question. Representative Upham.
You can do that.
Oh, thank you. I wanted to ask Colonel Grady, if it's a short answer, what is the VA lacking that it's not a full service hospital?
I'm not certain of the exact requirements for a full service hospital. My guess is that we're not doing 24-hour-a-day operations, and our surgical capability isn't kind of where you'd want it for a full service hospital. But I would need, I can, if you'd like, Representative Nutter, I can get, I'll ask that question to our folks at the VA and ask them to get back to you with an answer.
Thank you. I was just curious. Thank you very much, Colonel.
Yes.
I'm wondering if, in the interest of inter-service cooperation, if Army Major Laflamme might know that since he's a PA. I think he may be off the call.
No, it's straight for
Hmm?
Yeah, he's off the call. Oh, wait a
he's
minute.
not a-
Elizabeth Laflamme is listed and her hand's up.
Major, could you answer that question about why the VA in Manchester is not a full hospital?
I can. I did talk through my wife's, she's still streaming this after I left the Zoom. She's one of the PA students in question. But we are not beyond our long-term care facility at the CLC. So it is not a 24/7 operation. There are limited surgical service and does not have an ongoing inpatient wing. And it was, as stated previously, outside of New Hampshire, only Hawaii lacks these capabilities as states. So we do have a limitation.
Thank you. And
Thank
as,
you.
and as an Air Force major through the Civil Air Patrol, I thank the Army for that. Representative Knark.
Yes, thank you very much. I just didn't want Representative Nutter-Upham to be missed. So what I did is, just for those of you who have access to your email, well, Mr. Laflamme was speaking, I was actually trying to put together the things that came out as best I understood linguistically to make this better. We obviously don't have to wordsmith it perfectly now, but I want to make sure we have it accurate before the next time we get together. Representative Marsh and I just tried to do an end run and get this thing in place so that we could exec it today, but clearly we failed on that because we didn't have some good language on it. So if you are able to open your email, but I'll also just say it verbally. So what I addressed in that line 16, it would instead say, requesting licensure in New Hampshire may be supervised by physicians not licensed in New Hampshire, provided they possess a current license in good standing in their respective state or territory of the U.S. That way we have taken care of not excluding New Hampshire physicians. We've taken care of not excluding somebody from Puerto Rico. And we're not discussing where the physician is from, but simply the licensure. Then on line 22, I changed that to saying, although 21, 22, offering services to the state of New Hampshire and out-of-state licensed physicians accepting supervisory responsibility. In other words, not worrying about just that they're from out of state, but where they're licensed from. I just need feedback from people as to whether that satisfies the requirements of the discussion we had. And I do apologize, I will do this later because I think he's off the call, to Senator Sherman for not sending him this draft amendment. That would have been smarter, but I didn't. The other questions, though, that come up are that question that Representative Woods brought up about, did we suspend all regulations and rules, and should we insert a phrase just saying New Hampshire state license, this is line 7, New Hampshire state licensure laws, rules, and regulations regarding licensure and supervision for physician assistants, inserting the words regarding licensure and supervision to make sure that we're not suspending every rule for them. The last one, I guess, would be what came up then in that discussion about that not all care is at a licensed facility, and should we strike the language at licensed medical facilities, just that if it's coordinated through the VA. So if people could give me some quick feedback on that, then I will, with Bill Marsh, draft another amendment. But I want feedback from people. Do we need that change in line 7 that Representative Woods said? And again, the changes I put in red, I did not put the change from in the conversation with Representative Gay and Mr. Laflamme, because I was composing this as that went on and sent it and did not get that into there. So first on Representative Wood stuff on line 7, do we need to put a restriction on what the suspension has to do with? Or is it, or do you think it was already obvious?
It doesn't hurt, to me, it doesn't hurt if it's obvious to add it.
Okay.
I've
Then,
never been paid by the word, but I think it's a good concept sometimes.
fair enough. And then line 11, shall we strike the language at licensed medical facilities outside of the Manchester VAMC? Just because then that, if you're doing home care, that is not being excluded?
Jerry, Representative Kinnerk, I think we should be careful because there needs to be some language in there to ensure that the relationship between the facility does exist with the VA under contract to some capacity. It does open up relatively large. The other question I'd say, as long as I went through amendment suggestions, the other issue which I didn't raise before, if you're an out-of-country physician or PA and you prescribe in New Hampshire, we cannot fill the prescription at a pharmacy. We'll have to go to the VA because we're only allowed to fill a prescription by a licensed physician or PA within the confines of the US.
Fair enough.
As long as
But
everything.
again, in this case, all we're doing is changing that issue about the supervising physician. They already have the out-of-state PAs there, so I don't know.
It's out of country. As long as the out of country is taken out of it completely.
Oh, well, that's good, but that's gone anyway.
All right. But the other one, though, is I'd rather be sure that we have some sort of restriction, or we intend to have a contractual relationship between the VA system and whatever the PAs overseeing or working in.
Well, the language would still be there that would say offering medical services coordinated through the VA. So it'd have to be coordinated through them. There'd have to be a relationship. That language would be still there. It would just that's line 10. It would just take out line 11 that talks about at licensed medical facilities.
I think
does that still work for you?
I think the word coordinated is kind of broad. I think it could be okay, but I think again back to the same thing where it's obvious is that there is a contractual relationship, because if the patient does go to that facility, is they're really trying to do is they're coming under the auspice of the VA system, and that should be done through a contract, not just the fact that they're coordinated. So the patient is getting the same level of care and services that they would have in the VA system itself if they're outside of it. So that only can be done, and we only can ensure that if there's a contractual relationship between the VA system and the facility.
We participate.
Can we hear from the lawyer?
Well, I've got a few more in the queue here. Thank you, Representative Merchant. Chair recognizes Representative Nelson.
Unmute.
Unmute.
Unmute. There we go. Sorry about that. Line 18, it says Territory United States. What is District of Columbia considered?
I just looked it up. It's a territory.
Yeah.
Thank you.
Thank you, Joe.
Anything else, Representative Nelson?
Thank you. That's it.
Okay, Representative Weber.
Thank you, Mr. Chairman. I was going to suggest on line 10, instead of saying coordinated through, if we perhaps used the words offered by, because that implies that it's coming from the VA. And I think it might have a slightly stronger nexus for the concerns that were raised. I think it was by Representative Woods, but maybe it was by Representative Merchant. I think the issue of the suspension of the laws, rules and regulations, having been in the original language, which we have operated under for years and years and years, is not so much of a concern to me, but I think having the qualifier in there is probably better practice, because we want to make sure we're saying what we're giving guidance about, but make sure that is vetted really carefully with the practitioners from the VA to ensure we're not restricting something else that they actually need to do. So those are my comments.
Yeah, may I quickly speak to that though? That language was not there for a long time. That was put in under the emergency order. That's 328D2A. 328D2 was what was initially in there and did not have the things about the suspension. That the language about suspension all had to do with the emergency order because of COVID. So that's the thing I'm concerned about, is it might have been some sloppy drafting when it was put together back last year.
Clarification.
Yeah.
As I'm looking at this, oh, maybe because I'm looking at the amendment. Let me look at the original. As I look at both the amendment and the original bill, it seems to be indicating that the language on lines 7 and 8 were part of the original statute, not an amendment.
Yes, but it's part of the original statute 328D2A that was put in place by executive order, emergency order.
You
So
cannot
it's not,
put a statute in place by executive order.
well, then what is all this?
Either a statute or it's not. So I'll go and look it up and see what it says.
Yeah, take a look, because it has this large preamble of all the executive orders that led to it, and it's why it's labeled D2A. But I appreciate that it's not by statute, but somehow it got in response. So I think that has only been there. It was effective June 14, 2018, though. So I'm getting more confused as I say. So I don't know the answer, Representative Weber.
I'll look at the underlying statute and we can discuss more.
Great,
but
thank you. I'd appreciate that.
amend the statute,
And I will run this. I'll run this final language by Representative Weber and obviously by Mr. Laflamme to make sure that it's satisfying the VA needs. I'd run all the other stuff by Mr. Laflamme before Representative Marsh and I put this together. Okay. What about the wording though, the wording that I put in to try to solve this thorny thing about out of state and all that stuff? Are people okay with that currently?
I have fewer words.
Representative Gay for fewer words.
Okay, line 17 in the amendment. Well, starting 16, may be supervised by physicians. Skip from other states provided they. Just say, but may be supervised by physicians who possess a current license in good standing in their respective state or U.S. territory.
Okay.
And there's one other word change I'm suggesting. Line 10, coordinate, okay, currently says coordinated through the Veterans Administration Medical. Okay, instead of coordinated, how about administered by the VA or provided by the VA?
I will defer to Representative Weber on that one.
Representative Knerk, you ready for another question? Or
well, I think the question about coordinated through, offered through, or whatever Representative Gay just came up with, I would want to defer to Representative Weber, who offered that phrase "offered through" as to what makes the most legal sense. She is our token lawyer on the team.
we have lawyers as well at OLS.
Yeah, I know.
But I know
they missed it the first time.
They're not us. Okay. I'm going to suggest we move towards wrapping up what has become a work session.
Yes.
And I'm going to call the people I have on my list and then close the hearing, become work session, awaiting good work. And because the first bill we heard means we've got to come back, then we'll come back for this one as well, probably in a couple of weeks. Representative Shapiro.
Yes, not wanting to be wrong, I once again Googled, is Washington DC a territory? And it is clear that some people think it is and some people think it isn't. And so I would probably just bring that up with the people from OLS and have that defer to them for language that would be inclusive.
Thank you. Representative Weber.
I just wanted to say that I looked up section 328D:2A, and when you look at it, there's a huge chunk of language referring to emergency orders. But that's just telling you that you need to go and look at those emergency orders and see what the emergency orders say, because they do in fact modify the existing language. But the existing language says New Hampshire state licensure laws, rules, and regulations are hereby suspended. And it has said that since 2018, which is when the initial language was passed. I still don't have a problem clarifying it further.
Thank you.
Thank you. Representative Folsom.
Oh, well, I was just, sorry, I was going off of what Representative Weber said and Representative Gay and the confusion over the coordinated through. I would agree with Weber because if you notice everywhere else, like in line 8 and line 15, they use the word offering. And if we stick with the word offer, I think it provides a continuity and a consistency.
Thank you. And Representative Merchant.
My question was answered. Thank you.
Thank you. Okay, anything further? I would suggest individuals may call Representative Knurk. We've done an awful lot of work on about 26 lines. So with that, I am closing the hearing from work session on Senate Bill 120 as amended. I'm not closing the hearing yet. I have a few things from me, and then we have something from Representative Snow.
By the way, just a quick thing. This is reminiscent of our 1 hour on shall and may last year. It was wonderful. Thank you for all your help.
We have to do this to make the 7 new people to the committee share a history with us. All right.
Quick question.
No, we're finished on this. You can call Representative Knurk if you wish, or Representative Marsh.
But you're going to finish this.
We
up.
have
You are.
5 retained bills. At present, we may wind up with another one, but right now we have 5. 103, you may wish to write the numbers down so you can look them up. 103, an act establishing a dental benefit under the state Medicaid program. 247, an act relative to treatment alternatives to opioids.
That number again.
The second one was 247. The third one is 314, an act relative to homestead food operation licensure. House Bill 602, reimbursements for telemedicine. And House Bill 604, an act expanding the New Hampshire Vaccine Association to include adult vaccines. We have these 5 retained. I know I still have the list of people who wish to be on mental health bills versus other bills. But if anyone was interested in saying you would like to be on any of these, I'll accept those emails and try to jiggle together some work sessions a couple of months from now. Also want to point out, and actually a couple of committee chairs have pointed this out to me under, gosh, you guys sure do have a lot on consent or 19-2. And I think that is because of the procedure that just sort of evolved into existence of a Republican grabbing a Democrat after a hearing and saying, you know, I think we can bring together good points you have and good points we have and have something that isn't maybe a compromise, but maybe more comprehensively good. And you brought that amendment to an exec session and all of us or most of us agreed. And I think that's why is that process. And so on these retained bills, when there'll be work sessions on them, and on the two bills we looked at today, Senate Bill 45 and Senate Bill 120, I think this is, at the risk of being a poli-sci professor, this is a lesson in how we get things done. I certainly have some non-negotiables. I have ideology, I have certain moral tenets, and I'll stick to them. But most of the bills we have are not that, or not that to a great degree, or to a degree where my views and the views of others can be accommodated if we work for it. And the idea of let's work towards that means, as Teddy Roosevelt said, the hero is the one who makes mistakes but is engaged in the process and not sits on the sideline. So as we go forward, I'd love to see more bills, as many as possible, knowing there's a few that will not be this. The more that we can come out with a happy agreement, the better. I think we've enjoyed that. And I think that's something that we can more intentionally work towards. So I'll be happy to receive your suggestions as to which of these bills work sessions you'd be like to be on, and I'll let you know, but don't expect it for a couple of months. Part of that is we have to wait to make sure there's enough technical staff available because work sessions are public events. Now,
How many people?
What's that?
How many people do you want to put on these?
Don't know yet. Don't know yet. I mean, if you only have a few, you don't get all the possible points. If you have too many, it becomes unwieldy. Don't know yet. Less than half, but still. Now, Representative Snow.
Thank you very much. One other question is, I don't think I have the most recent amendment to 120. Do we have any printed copies of the one we was actually working on?
The one we were working off, part of the time was 1107.
Yeah, that's not the one I have. So.
Okay, there's 1107, and
that's right. The other one that I sent out was just something I was doing as a little work product as we were working, so people could see it in writing. So Ken, I sent it in the email to our committee, but don't worry, it's not an official amendment yet. That's what we'll work on.
Thank you very much.
And now the bill that's...
Yes, one of the concerns I have is a bill that we passed in the last session. It was a very brief bill. It was 2 paragraphs long. It was a very simple bill. It simply looked at Medicaid in and out, which is a service that's provided to individuals whose income is too high to qualify for Medicaid, but they have ongoing medical expenses that are so high that they couldn't possibly meet those obligations with their income. So it was a law that was passed 30 years ago that said if that income is, if they spend down to what was determined to be the poverty level, all medical expenses beyond that are going to be covered by Medicaid. You have to do that each month and so forth, but it does work. However, as you probably are aware, the cost of living has gone up somewhat in the last 30 years. So what we did was we tried to modify what that base was going to be that the spend down had to come down to before they qualified. And that passed this committee, I think it was 20-0. And it passed the Senate. Senator Sherman was very involved in that. I was hoping, is he still on? Or did he get off? Oh, okay. See, part of what I was doing is, as long as we had him as a captive audience, I was going to try. I've got to call him about this. And it was signed by the governor. Now it got confusing because House Bill 1639 was the number. It was 2 paragraphs long when I wrote it. When it was finally passed in the House, the title was changed from Medicaid in and out to healthcare concerns or something like that. And it became 39 pages long. And it was what was euphemistically called a Christmas tree bill, remember, because of all the complications going on in the Senate. But it did pass, was signed by the governor. And currently the Department of Health and Human Services is under an obligation to meet these new guidelines because we passed that law and it was signed into law. Unfortunately, the governor did not include any funds to increase the money that was available in the Medicaid in and out. And when I spoke with Representative Edwards, I didn't speak personally to him, but when they made the report, I asked the question, had they included any money to fund that? And he didn't seem to be aware that that was something that needed to be done. So it was not included in Division 3's budget. So I'm hoping that somehow we influence the Senate to incorporate some number. What that number is a mystery to me. It's very confusing because we don't know who's going to qualify to go in, who no longer have to do in and out, but some people now fall under the new guideline and they'll go into the regular managed care program. And others, so it's you know, the fiscal note was an absolute nightmare, and the department didn't really know how to figure out what it was going to be. I've made some calls and got a call back yesterday. I haven't been able to take it because I was on another Zoom call, but Tim Lipman, the head of Medicaid, I asked if he could be of any assistance to us to try to figure out. I said, we need some kind of a number to at least be included in House Bill, in budget bill, either House Bill 1 or House Bill 2, so that this doesn't get off the ground, because as you know, there were a number of cuts to the Department of Health and Human Services. They lost a number of positions, a lot of other things. So they don't have a lot of flexibility to suddenly start funding this at an additional level, especially if we don't have any idea what we're asking for. So I'm going to call Senator Sherman and Senator Rosenwald, who are both on the Health Committee. And I think of any of the others of you, this was a bill that was very important to this committee, I think, and it makes common sense. I mean, this affects a lot of people with mental illness, but it also affects people who are on dialysis or have other ongoing medical expenses. It can be pretty overwhelming. So I think it's a pretty important bill, and I hope that whatever we can do, just to say, sorry, there was an oversight, this was never included in the budget. We need to find a way to now include some figure in the budget. So they are, because they are obligated to now meet it. It's been signed into law. You can't go back to the old way of doing it.
Senator Snow, you picked a tremendous time to find the unmute. This is great. And I hope that you will keep us all in the committee looped in as to when you talk to Mr. Lipman and so on and so forth, because I think this, there may be time to talk to the Senate in terms of their budget now that we sent it to them. And Senator Guida, who was here before, is on that budget thing. So he'd like to know, I'm sure. Our alumni in the Senate, Senators Sherman and Rosenwald, I'm sure would be very interested. So you send us what we need to know, and you make suggestions on how we can help.
And what I was really hoping for today is that he'd still be on. So just trying to get through to these guys right now on the phone is a real problem. And, you know, I don't know about you. I don't know if you get as many emails as I get. You know, certainly sending an email, you kind of wonder how serious the hell I'm going to be.
I'm texting.
Yeah, I would too. Thank you so much for that. And I'm sorry, that was not an official gavel. I just dropped it. Representative Weber.
Sorry, I think that the ending remarks took care of what I was going to say. I mean, the only thing that can help, particularly right now, is getting in touch with the senators on the Finance Committee in the Senate immediately, if not sooner, and making sure they're aware, because the department is under an obligation to fund it, whether it's in the budget or not. And if they're under an obligation to fund it, then that means more funds have to come from somewhere else. And I'm also going to apologize to the committee for having been so slow at muting and unmuting. I made a terrible experiment last night in that I decided to try glue-on fingernails for the first time in my 68 years, and I am here to tell you that I have glued my own fingernails to my skin, and in at least one case, I have glued not one but two fingernails on top of my own fingernails. And I should perhaps have read the instructions, because I gather I'm now going to have to just wait for the glue to loosen of its own accord. So I can't actually operate in the ways that I used to. And I know people can do it because I've seen them do it, so I need to adapt, but my apologies.
Representative Weber, I have two responses to that. Number one, I know a retired hand surgeon. He's really good. And secondly, if I ever was tempted to try glue-on fingernails, you have convinced me it's a bad idea.
See, I'll say I've been there, done that.
Well, thank you all. And now the official gavel drop. This ends the hearing for the House Committee, Health, Human Services, and Elderly Affairs. And you're going to notice we'll probably have an exec session in a couple of weeks. And I'll keep the cards and letters coming.
As a PS, the good news is that those people who should qualify by the law are entitled to the benefits. It's a courtesy to tell the budget that they need to expect it.
Well, yeah, because if the HHS doesn't have the money, it's going to come out of some other. And who's